Now we're going to see multiple myeloma. Multiple myeloma is a monoclonal proliferation of plasma cells that secrete IgG or IgA. Could be also the other immunoglobulins, but the most common ones are IgG and IgA, and of these the most common is IgG. So we would have a spike in serum electrophoresis. Remember, we have albumin, alpha 1, alpha 2, microglobulins, beta, and a M spike. Now the M spike is very small, but in patients with multiple myeloma or MGOS, monoclonal gammopathy of undetermined significance, or Waldenström macroglobulinemia, this we will have a M spike due to the increase in IG immunoglobulins. In this case are IgG or IgA. In Waldenström was IgM. So the best initial test would be serum electrophoresis. We could also see in urine electrophoresis, but note that we will not see anything on a reactive dipstick, because that only detects the protein that is detected there is only albumin. We will have a increase in total proteins, but the albumin will be decreased. Now this is due to increased production of IL-6. This IL-6 increases the RANK receptor expression on the osteoclast, and so there is activation of osteoclast. This is a lytic lesion, so we would have a lot of bone lytic lesions, so the patient can present with fractures, pathological fractures. Because of this increase in lytic lesion, we have release of calcium, so the patient can present with signs of hypercalcemia like confusion, constipation. And the patient would have anemia of chronic disease, for example. And because of increased immunoglobulin production, they could have amyloidosis of the kidney. So these are the CRAB findings: hypercalcemia, renal disturbance, renal damage, anemia, and Baines-Jones proteins. The immunoglobulins are called Baines-Jones proteins that are only seen in electrophoresis. Now, the most accurate test would be a bone marrow biopsy, in which we will see more than 60% plasma cells. These plasma cells sometimes can have the Russell bodies. These Russell bodies are plasma cells with immunoglobulins inside. So the patient can present with many things: bleeding, including bleeding and pathological bone fractures. These would lead to not only the treatment of the neoplastic production of plasma cells, but also for the fractures we can give bisphosphonates that don't act at the moment. It takes like 2 to 3 days in acting, but we give biphosphonate like solindronate. For the calcium, we need to treat it usually with saline solution, normal saline, IV fluids. Now, the treatment of multiple myeloma includes, if the patient is less than 70 years age, we can go with a autogenic allograft or autologous transplant of bone marrow. If it is greater than 70, we treat them with prednisone and melphalan. Patients that are candidates for, let's say, a transplantation of bone marrow also need chemotherapy before, and we do it with prednisone or dexamethasone and thalidomide or lenalidomide. These two are inhibitors of tumor necrosis factor and can have neurological side effects, but is a corticosteroid with an inhibitor of tumor necrosis factor before giving the bone marrow transplantation. And those that cannot undergo bone marrow transplantation, that are not candidates, we give prednisone, melphalan, and rituximab or thalidomide, usually thalidomide or lenalidomide. Sometimes we can give other medications like bortezomib. Bortezomib inhibits the proteasome, so there will be accumulation of proteins in the cell and will ultimately kill the cell. The drug melphalan is not curative. It's given for patients greater than 70 years old, but it is not curative. It's just the same as hydroxyurea is to essential thrombocytopenia or chlorambucil is to some leukemia. So melphalan is not going to cure it, but we give it in patients that are above 70 years age that are not candidates of bone marrow transplantation. If we don't have fractures, so let's say that the X-ray is normal, but we continue to suspect this, we can do an MRI or CT scan or a PET scan in order to look for the increased activity. Now, in a nuclear testing with technetium of the bone, we would not see anything because that detects osteoblastic activity, and here we have osteoclastic activity. Actually, this is the only neoplasm in which there is poorly osteoclastic lesions. Other diseases or cancers that produce predominantly lytic lesions, but they produce predominantly lytic lesions, not completely lytic lesions as seen in multiple myeloma. So we would have the increase in proliferation of plasmatic cells, but because it is monoclonal, it's only one type of immunoglobulin, the patient will have hypoglobulinemia, and so the patient is prone to infections.